This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
We're really challenged from a lot of different places. And so that means we are going to have capacity challenges inpatient and in the emergency department and observation and our labs and our clinic, not only in the CV service line, but really broadly across healthcare.
Hello, and host today, Tori Richie, and I am joined by one of our esteemed service line experts focusing on all things cardiovascular, Josh Aaker. Josh, thanks for joining me.
Thanks for having me here today.
So Josh, we just wrapped refreshing the forecast for the 2025 release. I am just seeing visions of upward arrows on inpatient, outpatient, emergency department, OBS utilization for our cardiovascular patient population. What are the trends that we're capturing here? What's driving that growth?
There's a lot of trends that are coalescing into the perfect storm. And even more unfortunate, it's often the CV service line is the center of that. I'll just take a step back. Why is the CV service line the center of it? And what are the macro trends that are driving this? If we think back to the start of the COVID-19 pandemic, when patients were presenting in the ED, you often had to do a cardiovascular rule out. CV has often had to be the front door in the ED. We're often commandeering observation. Maybe we call it a chest pain center or clinical decision unit. When you think about people with hypertension or hyperlipidemia or peripheral vascular disease, that's out in the community. We also have to manage heart transplants in the future of xenotransplantation. The CV service line is being asked to do a lot across the entire system of care. What's going to be challenging is we have the silver tsunami being here. We're going from 1 in 5 Americans being over the age of 65 to 1 in 4 by 2050. Not only are our patients getting older, our clinicians and our physicians and our administrators are also getting older. So let's think smartly about succession planning. We have an aging population that sits squarely in the CV service line. The average age of a TAVR patient is about 80 years old. We are well into the Medicare population. But we also have data coming from the American Heart Association and from a lot of other sources that the underlying risk factors that drive all chronic disease but are exemplified in CV are growing. That growth in hypertension, that growth in obesity, and even some of those behavioral changes that we're seeing are scary. For example, cigarette smoking overall has gone down. For those people over the age of 65, it's held relatively consistent over the past 4 decades of about 9.2 to 9.7%. We're really challenged from a lot of different places. And so that means we are going to have capacity challenges inpatient and in the emergency department and observation and our labs and our clinic, not only in the CV service line, and we'll use this as a case example today, but broadly across healthcare.
There is this unique bifurcation of what is playing out today. Patients that have these complex chronic conditions, they require the care that they require. There's a certain element of blocking and tackling. Let's start there. What are some strategies that you've seen providers or organizations implement for our cardiovascular patients to make providing that care a bit more efficient, to be able to then scale operations to meet the needs of a growing cohort of individuals?
Strategy 101 is gap analysis, or where are you right now? This is a tool that we used with our cardiovascular network a while ago, our IPS tool, or broadly our optimal mix tool. One of the ways that we looked at this was not just the change in volumes. That's easy to look at, but at SG2, we like to look at more complex analytics. We also wanted to factor in what is that length of stay change over time, because that is one of the underpinnings of our impact of change forecast. If you looked at just taking sample hospitals and looking at the projected growth over the next decade, what was really filling up your hospital was your congestive heart failure patients or your heart valve disease patients. That was because the heart failure patient population was clinically growing. And so that was a longer length of stay that were more difficult to manage. But on the other side, that heart valve disease was growing because that clinical population was growing. We happen to be doing really fantastic in reducing the length of stay. But if you're adding in 100 more patients and you're reducing your length of stay by 2 or 3 hours over the next year, at some point, you're going to need more beds. So firstly, it's stepping back and saying, what is our challenge? And is it primarily because of the patients we have? Is it our workforce? Is it our inpatient? Leaning on your tools that you have. And also our system of care is a fantastic way to step through with your strategy team to take a step back of what are the challenges we're having? What are the solutions that we've primarily been seeing? Inpatient space. If congestive heart failure truly is one of those barriers, and frankly, it's been challenging for decades and it will continue to be challenging for decades. It may be optimizing outpatient clinics or being proactive. Even if patients do come in and have to be admitted, those decompensated patients are maybe not having to stay all 7 days. Is this an opportunity to have some step down clinics? Is this an opportunity to highlight your hospital at home for well-managed patients? Definitely some ways to think about how chronic disease is being a boulder in not only your CV service line, but making it challenging to dynamically use your inpatient beds. The other side of that coin was the heart valve disease. Relatively healthy-ish patients, knowing that the average age is 80. So these are not young necessarily patients, but can we be proactive about using protocol standardization for same-day discharge? This is something that we saw, to harken back to COVID, that the 1%, 2%, 3% of patients receiving TAVR had same-day discharge. What was more important for us was that the number of hospitals that had experience with at least 5 same-day discharges was increasing. It will probably never be that a majority of your TAVR patients are going to be same-day discharge. When you reach your ceiling, that's a really fantastic way to know that you've standardized your protocols. Focusing again on those heart valve disease patients, it's making sure their average length of stay is being watched and managed. But what does that lab space look like?
That, and there's such a demand on the lab side. Then my question, how do we execute in that space? Because there are also a number of barriers to entry that providers are navigating. And so how do you continue to push growth in face of some of the headwinds?
First of all, understand that there is not going to be a singular solution for a single service line or even for a single area of a service line. Think really broadly. This is where you're digging into your tool belt. This is about resource allocation. This is about procedure shifts, care at home, operational improvements, which you were talking about, and that ambulatory access. You're going to have to dig deep because there are going to be different solutions for different aspects. And if we were to talk about the lab space, we have a calculator that we've been using for almost a decade. It's highlighted in one of our most recent publications, The Rising Tide of CV Disease. And it's essentially a cath lab calculator to help us model out the change in volume. The volume of cases in our model cath lab that we're presenting is relatively flat. But it happens that the length of cases that are going in there is increasing. All of a sudden, you need to find a fifth of a cath lab just lying around a decade from now. It means evaluate what the ROI is of additional labs or surgical suites. Is this about building a new lab? Is this about workforce optimization? This is really about getting people to just do on-start times, because that's sometimes a bigger lift than having a new lab being built. But I understand that politics can be important. So optimize that existing capacity. Think about, do you need to change your workforce setup to help get those extra ablation patients through one day? Because we know that that has been a real barrier to success. There's going to be a ton of different challenges, but you have to know what your problem is first. Having shared data allows for a shared reality and then the shared problem solving. That's where I would start as we think about those labs being at capacity. And frankly, that demand is only going to be increasing over the next 3, 5, and 10 years.
If those are some of the strategies that we should be deploying as we think about optimizing lab space and lab utilization, are there commonalities then between that and how we should be thinking about optimizing delivery from an OR perspective as we think about the procedural forecast that continues to grow as well?
If we're talking about capacity, then the other word that we need to think about is efficiency. Using things like AI tools to do risk stratification. So do you need your anesthesiologist to be present? Using that risk stratification is not only important for the right location within a hospital, but it could be, does this patient need those procedural services at all? Or could we transition them to, for example, non-invasive solutions? I think about our chest pain centers or our chest pain clinics for people showing up. Those low-risk patients, in the past, we've maybe had to perform a nuke med imaging on them, or we've been really nervous, and so we have thought maybe let's progress to a diagnostic cath. But I've been talking to some members who have been trying to energize those services that they're offering because they have capacity constraints. They're an opportunity to allow for more behavioral health space, for more emergent walk-ins that are coming into that ED, freeing up those spaces. And for them, they're having rapid rule-outs with high-sensitivity troponin and shifting those patients that would have gotten diagnostic cath to a CT forward perspective. And what's interesting from a financial perspective is when they use this methodology to appropriately redirect their patients from rather the ED and then maybe the ED to inpatient admission, getting that DRG, which is a lot easier to show off to your CFO, they saw so many more downstream clinic visits following those patients to ultimately may need more intensive procedures. They actually made more money on the clinic visits than they did on the lost ED inpatient admissions. That's challenging because that means now you have to think about what are your bottlenecks in that ambulatory clinic space. But now that opened up a huge set of beds on that high cost campus that you can fill with better patients and maybe increase that CMI.
We've talked a lot about capacity constraints that organizations are feeling and the need to operate more efficiently. We're also feeling supply constraints related to workforce availability. And you hit the nail on the head at the onset of the conversation. Our medical staff is getting older, and there aren't necessarily people that are able to backfill one-to-one as folks are leaving the workforce. So have you seen any improvements in how we're deploying our workforce, how we're recruiting and retooling the workforce to be able to expand those provider to patient panels?
This is a larger discussion, so it's a little controversial. I won't get into too much of it, but CV has thought of themselves as maybe we need to separate out a little bit from how we've done our board certification. If you just separate out that controversy, it may mean you're thinking about your APPs, you're thinking about your CNAs, your CRNAs, maybe even your dietitians, and saying, are you really focused or are passionate or interested in geriatric patients or chronic disease patients? FYI, that's the CV patient. Creating internal pathways to help specialize those types of other clinical specialties to help influence the CV service. And again, we touch so many people, going back to the American Heart Association's disease projections. If you include hypertension, by 2050, over 61% of Americans will have some cardiovascular disease. Is this the CV service line, or is this the primary care plus of services? And we don't want CV to be that. We want us to continue to focus on where our specialties lie, but that can mean enabling and training our colleagues all across the different spectrum, enabling those dietitians to help create a functional cardiometabolic clinic, or developing pathways for not only anesthesiologists, but CRNAs as we move into some lower acuity procedures, particularly as we think about the adoption of pulse field ablation. What does that change potentially in 3 and 5 years mean for the requirements for anesthesiology? Maybe now we're having one anesthesiologist monitor several rooms rather than having to have more closer one-on-one to a patient.
What is your recommendation as a starting point if organizations are thinking about how to navigate, number one, growing patient demand within constrained capacity as well as workforce supply? Is there a stepwise approach that we should deploy here to figure out how to solve the equation?
It's first of all doing an assessment of where your capacity constraints are, and then also what are the obstacles to those capacity constraints. It could be physical space. It could be workforce. It could be just you're not aligning your workforce to start on the times that you need them to. But understanding where that is probably the first step. The next steps are going to be informed by that, but it is all about leveraging all of the resources that you have. Is it going to be hospital at home and remote patient monitoring? Is it about shifting some of your patients to non-invasive solutions, whether that's medical management or some type of imaging and long-term monitoring? Optimizing your capacity smartly, if that's going to be an ambulatory shift, if that's going to be some regionalization of complex services, is it going to be some of that care at home, whether it's virtual or not? You're going to have to build additional capacity because everything we're talking about has been managing this incoming wave. And some markets are going to be further behind. I was talking to someone in the middle of America and they did not yet see that silver tsunami. And I was like, wow, I'm jealous. You have plenty of time to think proactively about this versus some of our clients in New England. They have had an older population for quite a while and have been bursting their seams. Capacity is probably the word of this podcast. So you get a little bit of a preview. Is going to be the primary focus of the cardiovascular landscape webinar this year. So mark your calendars. It's July 9th at noon Central Time, but we're going to see some of these tools in action and hear how organizations have used them to manage their capacity smartly and in some cases proactively.
Josh, really looking forward to that webinar on July 9th. And before that, if folks listening today are interested in other thoughts that are ruminating in your mind, they can check out the CV Expert Insight, which will be released mid-May. Always a joy to have you on the podcast and looking forward to the CV webinar on July 9th.
Thanks again.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.